Awareness Month. So we wanted to make sure that Morgan had an opportunity to share what's been happening in the world of lung cancer screening and care, as well as how it applies to Colorado and even nationally.
Thank you, Janice.
You're welcome.
Thank you, Carlin. I just want to say I'm very thankful for the opportunity today. So thank you all for joining. My name is Morgan Shan. I am a co-chair for the Colorado Cancer Coalition's Lung Cancer Task Force. But I also I'm based in Manhattan, New York, of all places, and I work for a company called Flatiron Health. We're in the real world data space, specifically with oncology. So we have an oncology EMR service. We also have a lot of research work that we're also doing in the oncology space. And I specifically work in regulatory affairs. So that's a little bit about me. I'm going to go ahead and share my screen and get started with today's presentation. Okay. Can everyone thumbs up if you can see the slides? Okay, awesome. Okay, lung cancer screening, where are we and where are we going? This is going to be just a brief agenda of what we're gonna discuss today, and I'm just gonna get right into it. Okay, so what is lung cancer screening? It's a relatively new tool compared to other screenings like colon cancer screenings or breast cancer screenings. And it's done by completing a low dose CT scan on the patient. Specifically, we do low dose because that prevents radiation exposure. And in terms of the frequency of those scans and how often they occur, it really depends on the results and the patient's overall health history. So for instance, if you don't have any nodules or masses, usually at that point, screening is prescribed annually. So that highlights one of the key components to screening is that, you've got to be consistent and show it for those scans at least on an annual basis. If there are nodules or masses or something that we think needs to be monitored more, they do require additional screening or treatment, and it's based on size, location, health history, a lot of other different factors. But there is a radiology criteria called lung RADS, and that is the criteria that radiologists use generally to determine the risk of any nodule that shows up in a scan and what the care for that patient should be going forward. So the current state of lung cancer screening, where are we right now? There's definitely awareness and understanding for lung cancer screening. It's growing. I don't think we have as much awareness compared to other screenings like for breast or colon. And there are kind of three factors that influence that. One, from a literature standpoint, there haven't been a ton of studies that are statistically powered the way they need to be to support lung cancer screening. So the top two are the National Lung Cancer Screening Trial, and the most recent one was the Nelson trial, which was done out in the Netherlands. Those have been the two most powerful pieces of literature, and we'll talk about those a little bit more. But another complicating kind of component to lung cancer screening is it has a pretty strict eligibility criteria. You have to be so many years old. You have to have smoked so many cigarettes for so many years. It needs to be so many years since you quit. So there are those factors that are contributing and can make navigating whether or not a patient is eligible a little bit difficult. And then the third thing there is stigma. We know that statistically, smokers are less likely to go to the doctor for healthcare compared to non-smokers. And part of that is there is this sense of shame of still being a smoker. And smokers maybe aren't ready to quit or don't want to have that conversation with their doctor. So they just don't want to go, and then also from the medical community, there is this notion of stigma and personal responsibility, and to what degree do those go hand in hand for tobacco use? So there are a lot of contributing factors into lung cancer awareness screening awareness. But our hope is that the new U.S. Preventative Services Task Force guidelines, we think that that's a very positive piece of news for lung cancer screening, and we hope that that's going to ultimately increase uptake as more individuals become eligible. I'll talk a little bit more about that later. And then another thing that is important for lung cancer screening is provider education. That's been a hallmark of the Colorado Cancer Coalition's Lung Cancer Task Force, and we think provider education is very important. One big question with screening is who's supposed to really do the screening, and it comes down to the primary care provider. Well, primary care providers are very busy. They are being pulled in a ton of different directions. They have a lot of competing priorities. What makes lung cancer screening one of those top priorities? So that's been something that our task force has been working on in terms of increasing education, increasing awareness, connecting with those primary care provider groups within the state of Colorado, and really explaining the health benefits and importance of screening like this. Okay, I'm going to talk a little bit about the new U.S. Preventative Service Task Force guidelines. Just a quick overview for folks who aren't familiar with the USPSTF. I know that is quite an acronym, but essentially, and this is just taken straight from their website, it's an independent volunteer panel of national experts in prevention and evidence-based medicine. The task force works to improve the health of people nationwide by making evidence-based recommendations about clinical preventative services such as screenings, counseling services, and preventative medications. All recommendations are published on the task force's website and or in a peer-reviewed journal. So that's basically what they do. They look at literature, they look at research periodically, and they will put out guidelines for what they think is important from a screening or preventative health standpoint. So a little bit more about that review process. What are they looking at? How are they making this decision? Here's a link right here to their evidence synthesis. They looked at over 200 publications, 7 trials, with a combined number of over 80,000 participants evaluated. They, like I highlighted earlier, they highlighted the National Lung Cancer Screening Trial in the US and the Nelson Trial in the Netherlands. They thought those were the best powered controlled clinical trials in this instance. And this is a little bit about the history of how this task force has looked at these guidelines. Has looked at the guidelines for lung cancer screening. So in 1996, there was a grading of a D. They really didn't recommend screening. They did not think it was important. Fast forward to 2004, we still have a grade of I for like indeterminate. They're still not really sure if there's benefits there, but they're not going to necessarily discourage folks from doing that. And then if you fast forward again to 2013, you see we have a rating of a B, which is actually pretty remarkable that in such a short period of time, the attitude towards screening changed so quickly. So I think that's pretty remarkable. You'll see here some of the guidelines from the previous U.S. Preventative Service Task Force guidelines. You'll see that it says here in this green box below that you had to be at least 80 between ages 55 and 80. You had to have had 30 pack year smoking history. You've had to quit within the last 15 years. So those are the kind of the 3 prongs I want you to hold on to when you think about what those previous guidelines were and what the current guidelines that just came out were or are. These are the final recommendations. So you'll see here that initially they wanted screening to start at 55. The new guidelines recommend that screening actually starts at 50. And compared to the 30 pack year smoking history, now we have a 20 pack year smoking history. So the takeaway here is that they recommend screening should start earlier, and you don't have to have smoked as much to be eligible for screening. So those are 2 really powerful pieces that are really, I think, going to help folks from a clinical perspective. We still have the grade B recommendation. I'll talk a little bit more about kind of the pros and cons of that and what that really means from a clinical perspective. But all in all, this is really good news. So this kind of goes into a little bit more detail about these new recommendations. They were released in March of this year. We have that grade B recommendation. They recommend, again, starting at 50, 20 pack years. They still have the upper age limit of 80, and it still needs to, the threshold is that it should be in place 15 years since quit. So that's kind of that's still there. That is still something that we're working on in the community, what to do with folks who have quit for more than 15 years. Should those folks still be getting scanned? The jury's still out on that. But the way to kind of remember this is we've been using this this numerical acronym of 50, 80, 20, 15. That's been our way of kind of remembering. And I think that overall, these are, again, very positive updates to the guidelines. So again, some additional benefits. So again, the drop in age and PAC years are going to help address some of those disparities. Some of these figures were actually calculated or pulled by Debbie Dyer. She's another co-chair for the task force, and she's also affiliated with National Jewish and based in Colorado. So these figures are saying that the increase the increase would be 87% for those who would be eligible. So that's 80% for men and 96% for women. The new strategy will also help address racial disparities, particularly for African Americans and Hispanics, with a relative increase in eligibility of 107 and 112%. So again, those are some pretty incredible statistics, I think, and really showing what the benefits of just 5 years here and 10 fewer PAC years, what that does. Now, with that said, there are still some gaps occurring. I'm going to talk about those as well. This idea of a grade B grading or for lung cancer screening. So the issue with that is that grade B isn't necessarily bad by any means, but there is some concern that a primary care provider might not put as much thought or care into a screening that has a grade B rating, as opposed to something like breast or colon cancer screenings that have grade A, or cervical is another example of grade A. Those are things that you should be getting, and the thought is that maybe a doctor is more invested or more aware of those grade A recommendations as opposed to these grade B. Now, with that said, we have seen some feedback from the primary care provider community in Colorado that has said, just because something is grade B doesn't mean we're going to overlook it. So there is still debate on this. Obviously, we would prefer there to be a grade A rating for this screening. We think this would increase uptake of screening. We think this would encourage more individuals to ask their doctor or ultimately to get scanned. But we still think that, there's room for improvement. And yeah, that basically sums up the grade A, grade B, one of the things that we could improve on in future guidelines. Another evaluation, another component to consider is the guidelines for African Americans and for smokers and what that really means. So there has been some literature that's indicated that when you adjust for age and smoking history, African Americans actually have a higher risk for lung cancer than white smokers. So there is that concern there. We're not sure that these USPSTF guidelines totally encompass this population. We recommended that for African Americans, that maybe you start at a lower age for the screening and you require fewer PAC years. That might be able to better address this high risk population. So that's something that we think could also be addressed. And then the other thing, and this is, I think, probably the most important, is the idea of how this eligibility criteria only applies to smokers. It really doesn't take into account secondhand smoke, radon exposures, folks with family or genetic history of lung cancer for non-smokers. We haven't really addressed how to manage these populations quite yet. And there are varying factions within the lung cancer screening community that haven't been able to agree on how to address this unmet clinical need. There are some folks in the lung cancer screening world that think anyone and everyone should be scanned. There are some that think that it should be a more targeted population at first until we can really establish the benefit of this preventative screening service. So that's still something that that we need to work out. I don't think our task force would necessarily work this out single-handedly, but that certainly is on the minds of folks on a national and larger scale. So next step. So, where do we go from here? We do think that continued primary care provider education is key. Our task force has held 2 annual symposiums now on lung cancer screening, and we've specifically tried to target primary care providers in these instances and address some of the barriers to screening, provide potential solutions and workarounds for providers when working with patients to get them scanned. We've really explored a lot of the issues of this very multifaceted topic. So that's something that we've been working on, and we'd like to continue working in this space. Another thing we're thinking about is continuing to understand the lung cancer screening needs specifically for Coloradans. What are the state's barriers to screening? What are the specific problems in Colorado that we need to work on? And we have been working on that through the acquisition of some claims data through a third party named Civic that we work with. So Civic has basically provided us some claims data by pulling for certain lung cancer screening billing codes. We've been analyzing that data and trying to better understand this population, potential interventions that we can develop based on understanding this data, understanding of this data. So that's something that we're trying to work on too, is developing these very targeted interventions that are specifically going to help the state. Another way that our data has been used is, and Christy can maybe speak to this at some point, is we've been working on a marketing campaign for lung cancer screening awareness. And we actually used some of the data that we had on hand to figure out what zip codes to target and what populations in those zip codes to look at. So there's definitely this idea of more targeted interventions is really important to us. And I think that's going to be the future of how interventions are developed going forward. And then one last thing is we are still thinking about addressing gaps in current lung cancer screening policies and guidelines that include vulnerable populations. So we have one member in particular who's a lung cancer survivor. She's a very passionate advocate in the space, and she was a non-smoker. So one thing that we've talked about is we put together a radon subcommittee to address some of the radon needs in the state, and how radon is a contributing factor to lung cancer and outside of tobacco use. And there isn't a lot of awareness about this, so we've put some work there and some resources there as well. And we think that would address some of these vulnerable populations that aren't necessarily smokers, like we've talked about. So that's what I have for today. I'm happy to address any questions or additional feedback. My contact information is here. If you'd like to reach out offline, I'm happy to speak with you there as well. Thanks everyone for your attention.
Sure. Thank you very much. It was very comprehensive. And so the focus on screening for social workers often leads to, well, if they get a positive result, then what? What kind of supports are in place for them? Is your task force looking at different things that also need to be present to support people through the treatment process?
Yeah, absolutely. Absolutely. I think that the thing we focus more on is incidental findings. And looking at that from the clinician perspective first, and then seeing how that would translate over to the patient. But you're absolutely right that part of the shared decision-making process is the patient eligible for screening? Can they logistically adhere to screening on a regular basis? And sometimes the answer is, if they're not going to get scanned regularly, if they're not going to really participate, then maybe the answer is they shouldn't get scanned, And I know that's a hard thing for folks to hear sometimes, but that's certainly, if the patient is not, that's part of the qualities we think about for if a patient being a good candidate for screening. So if we think that something like anxiety or, some other factor is going to inhibit them from continuing to participate and monitor their health, then yeah, that's something that that's a talking point that the patient and provider would talk about during their shared decision-making process.
So my awareness is, and certainly Bonnie and Kristen and others can chime in, but my awareness is some people don't like to do the screening because they already suspect that it's going to be bad news, but they don't feel like they have the support financially or in family or in some kind of structure to be able to get the treatment that they need. Also, I think with the African American population, as you know, there's still a concern about, if I don't have really good insurance, am I going to be treated differently and get less quality of care? Do you have some data around how those things are being addressed with regard to perception of what happens after a screening in terms of support for these more vulnerable populations?
I don't have data on me today, but I can certainly put you in contact with another member of our task force, Jamie Stute. He is excellent. He's done a ton of research over at University of Colorado on stigma and lung cancer screening, and I think he would be an excellent resource to provide more insight on this. I'm just limited in my own personal knowledge of this, but I can certainly link you up with Jamie. I think he would certainly be able to speak to this more than I can.
Anyone else have questions or thoughts on this presentation?
Morgan, I thank you for sharing your talents. And I know you've been busy this month, especially with the symposium. I would just say that going forward, the cancer plan will be successful if we all kind of work together. And we certainly want to think of ways in the future to work together. Screenings are down overall, and that's a big concern. And so I think it would be nice to break out of our silos and connect. So please know we're looking forward to working together.
Absolutely. Thank you so much, Carlin. I completely agree with you that screenings are down. I think that this is something we've seen not just with lung cancer screening, but all screenings. I think the pandemic has really that's been one of the many detrimental impacts of the pandemic. We were looking at the data that I mentioned earlier, the civic data that looks at claims data and overall, number of screenings in the state of Colorado. And we noticed a huge drop between 2019 and 2020 in our data that we shared during the symposium this past November. So yeah, I completely agree with you. And yeah, I'm happy to also continue working together and collaborating on any efforts that you think where there might be overlap and we would be aligned.
I think one of the things that I'm struggling with here too is I know within Centura we have a new diversity, equity, inclusion, kind of plan, and they're starting to work on some of this stuff within our system. But at the cancer center, I'm going to see people after they've already been diagnosed. So I think Centura is trying to get out there and maybe educate people a little bit more. But I think that seems to be the struggle to me, is how do we get out there and reach these folks, because people are being diagnosed later. A lot of it's probably in relation to the pandemic, but where does this come from, and how do we reach these folks? I know we do have some screening opportunities and so forth, but I think to me that seems to be one of the struggles.
I think the challenge that we're seeing is there are many people with more than one diagnosis, and so whether it's at the end of their treatment in whatever sort of wrap-up session they have, or material in the waiting room or website, depending on how paper-friendly we want to be, just continuing to spread the word. Because once you're diagnosed with one cancer, studies also show that you're more likely to develop that second, third, and fourth cancer. So it's finding a balance of empowerment.
Absolutely. I mean, I think another thing to do is and I've floated this idea around in our task force, I think at some point, is this notion of combining screenings, so that if you can get your mammogram and your low-dose CT scan done together or at the same facility or something of that nature while you're already there, or maybe you schedule these scannings on a time that works best for the patient. For instance, I've definitely heard of some patients who schedule mammograms around their birthday every year, just so they remember, if you could do something similar like that for lung cancer screening, where there's not necessarily a stigma associated with it. It's just a matter of, oh, this is something I do to like keep myself healthy, right? So we've established that with breast cancer. We've established that with colon cancer, and we don't attach stigma to it. So for instance, we know that there's increasingly support that there's a link between diet and colon cancer, right? But we don't shame those folks for having a poor diet or eating too much of this or not enough of that, so it should be the same way with lung cancer screening. We all make decisions in terms of our health, and there is that degree of personal responsibility, of course. But just because someone has this illness doesn't mean that they should be treated differently, or get like subpar care or anything like that. So yeah, that would be my recommendation, is maybe looking at combining different types of screenings when feasible, just for less burden logistically on the patient.
Do you ever get the sense that screening can be done out in communities versus patients coming into a facility?
Sure. So there is this concept of a mobile CT unit, and that would be basically, it's a CT unit that's on wheels, and it would travel from place to place. And the benefits of it are that, especially in areas like Colorado, where someone might have to drive 30, 40 miles to the closest screening site, yes, there are advantages to having that mobile CT unit that can kind of come to you, or you could pick a parking lot in a shopping center, and have something there. The disadvantage is there are some issues from a technical standpoint with sensitivity with those scans. So you have to weigh those two. Do you want something that's more convenient and maybe you sacrifice a little bit of the sensitivity? I would argue that if the person is eligible to getting scanned, if they're high risk and really should be getting scanned, I would argue you should do the mobile CT, and that's better than nothing. But that's just my personal opinion. I'm sure there might be folks that say, well, we don't want to unnecessarily expose folks. We'd rather, what about this notion of false positive? That is still an issue with lung cancer screening a little bit right now. We don't want to have any guesswork with the sensitivity. We'd rather they come in, so there's two sides to a coin.
Well, so that is interesting in terms of radiation exposure. I mean, I sort of had this vision of the sun bus, the mammo bus, and the mobile CT scan all pulled into a parking lot, and people, sort of having a screening fair. And just wondering how the science would support that kind of exposure for people.
So you would have to really stick to the eligibility criteria. You would have folks that might come that might be eligible for, a mammogram, but not necessarily for the lung cancer screening. And you would have to have very skilled practitioners that would be screening those patients, essentially determining who could get screened. And shared decision making really should only be done by a physician. It shouldn't be done by any other sort of healthcare provider. That's at least the definite, that's what we go by. So there would be some nuance there. It wouldn't just be like a screening mill, if you will. So yeah, I think that's one thing to be careful of. The other thing is adherence. So if they get screened once, that's great. But what about the next year? You're going to do a mobile screening campaign the year after that, that's something else to think about as well.
Okay.
There are a couple states that have mobile programs.
Right.
I think North Carolina, was it Tennessee?
Yeah.
I think there's a few states. It would be interesting to see kind of what they're seeing.
Sure. And I'm not opposed. I'm not opposed to that, Denise. I think the mobile CT campaign would be an excellent idea. I think that's fantastic. My thought is logistically, for instance, from a funding mechanism standpoint, all of these public health programs we saw with COVID were cut drastically. There was a scholarship that we used to use to acquire this data that I was mentioning from Civic that got cut because of COVID. And then we had to re-strategize and think about another funding mechanism. So, I would think if you're going to do something like that, you would need to have a funding mechanism in place for at least 3 to 5 years so that you can really reap the benefits of that intervention. And maybe what you do is, folks agree to give their data, and you could have some de-identified data sets that show, look, we did screening for 5 years and this is that, and here's the correlation here. And then you use that data to support getting more money going forward, So I'm just spitballing here with you. I hope that's all right. And just thinking of like different things that you could throw against the wall for more uptake.
Okay.
And Janice, following up on the vision that you shared, I've had a similar vision with trying to figure out how we could work with 9 health fairs. Each 9 health fairs is kind of different on where they're located and what kind of what kind of healthcare partners they work with, but trying to help kind of enhance some of those health fairs so that depending on where they are, they can do some of the screenings. And then my other idea is that we have all these community hospitals, and I don't know how many of them have hospital weeks, but if they all have like a specific week where they're pushing health fairs, like I know Cheyenne Wells does a hospital week where they push blood work. So can we create some sort of infrastructure where we can send out more people to help with mammograms that day, dermatologists to do skin checks, basically like look at what infrastructure they have, what scanning technology do they have, and then really just have conversations with them like, what help do you need? How can we help you get people in the door to utilize your services and get established with care? So I think there's opportunities for sure. So I'd love to keep exploring these ideas.
Yes, because colorectal screening could be all part of that as well. I think and we have developed more of an interest in partnering with rural communities and helping them get the services and resources they need. So that may be something more that we explore as a coalition as well, to bring that all together.
One final area to explore as well could be just the community oncology services in general. So one trend I've noticed in the community oncology space is that they have been expanding the services they provide as well. So in addition to offering treatment, they're also offering prevention and screening. And I think the thinking with that is that, so for instance, with lung cancer, if you are a community oncology that focuses on lung and you expand your services to include lung cancer screening, in essence, you're catching all of those patients and potentially treating them, right? So there is, from a business standpoint, in terms of their overall model, that's why they're doing that. But with that said, if you build rapport with some of those community oncology practices and explain what you're trying to do, explain that maybe you might be willing to I don't know, send more patients that way, or market and say, look, this community oncology site is also offering screening XYZ. You can build a partnership there. You can build rapport there. That's just another potential opportunity as well, I think.
Bonnie, do you know if Rocky Mountain Cancer Centers are doing anything around screening, or is it primarily treatment only?
I don't know really, but I can definitely ask and see. My knowledge is more so around the treatment, but it'd be good to check.
Yes, I believe Centura and some of the other hospital systems are doing quite a bit in terms of what they can for screening, but I'm wondering if organizations like yours are also part of that equation.
Yeah, it's a good question. I'll find out.
Okay, very good. Well, are there any other questions or comments from Morgan before we let her go on with her day?
I just think there's so much that we need to do to constantly keep the message front and center. And I've been nodding to basically everything you've been saying. Like, this. I even find, like, with my friends, that despite all the Cologuard commercials on the radio, so few people know that the screening age for colonoscopies has changed. And so just because we think the message is getting out there, it may be that we need to make sure that the message has been heard. And we may need to just keep saying the same message over and over again.
Yeah. Sometimes people aren't ready to hear it, but if it's repeated often enough, hopefully you get a window of receptivity and it gets in. So.
Well, to Morgan's point earlier, I think getting lung cancer screening, just like even the knowledge of it, up to the same level as colorectal and breast. So even if people don't know the exact like age parameters, it's just it's one other cancer screening that we get every year or every interval. So there's a lot to do around lung cancer screening.
Yeah.
But it has a tremendous potential at saving lives. So
I think the repetition just helps to normalize it, that it doesn't need to be this big scary thing. It's just something that you do to help keep on track of your health and be a good advocate for yourself.
Yeah.
Exactly.
Yeah. And, just the assurance that knowing the truth about your health doesn't necessarily mean a bad thing. Some people would prefer not to know because then they think they have a reason not to act on it. So they wait until they're in crisis mode before they respond to get the care they need. And it's hard for people to think proactively, especially when they know it's so disruptive in their life to think about treatment. So. All right. Well, Morgan, you are welcome to stay for our business part of the meeting, but it may not be as meaningful for you. So if you need to step off the Zoom call at this point, that is perfectly fine. And we so appreciate your time and expertise, and we will be in touch, especially if more questions come forward.
Absolutely. Yeah. I hate to say this, but I've got pumpkin pies and cranberry sauce to bake right now. So I need to get started on that if that's okay. So thanks everyone for your time and for listening. And yes, happy to follow up if needed.
All right. Thank you. Enjoy your Thanksgiving, and thank you.
Thanks, everyone. Happy Thanksgiving, everybody.
All right.
Bye-bye.
Carlin, do you have the agenda ready to share, to put up on the screen, and we'll follow that along?
Yeah, let me make sure it's here.
Okay. Otherwise,
I'm at Cherry Creek, so I've been creative. All right, here.
You got it? I was gonna say I can pull it up too.
okay.
Can you see this?
Yes. Awesome. Thank you. Do you
All right, between the two of us, we're dangerous.
in all the right ways.
Give me 1 second and I'll make it larger.
Awesome. So this would be the part of our business we wanted, part of our business part of the meeting. We want to talk about some updates with the cancer plan and where we're going to need everyone's help on the task force to bring our part of the cancer plan to life. So Christy and Becky, do you mind talking a little bit about what this part of the project will require from our team and our task force members as far as some work groups that we have coming up in January and in February?
Sure. Yeah. So Bonnie and Krista, this is actually a really good time to get involved because the coalition just launched our latest 5-year cancer plan in July. And so task forces are embarking on action planning for the next 1 to 2 years. So you being at the table for these conversations can help guide which direction the task force goes in. But so what it's going to look like is there'll be a survey sent out, and then we'll have 2 additional meetings to our normal task force meetings so that we can really dive into prioritizing and picking what strategies we want to work on. And survivorship always has a lot to sift through because there's just one, there's so many survivors, and 2, there's just so much that we could do. And so we're really encouraging each task force to pick 1 to 2 goals to work on in the next 1 to 2 years. We can pick some, longer term goals as well, but picking 1 to 2 to really dive into and work on. So the additional requests would be responding to the survey, attending these 2 one-hour action planning meetings, and maybe some other email work in between, or maybe 1 additional survey, depending on how things shake out. But it'll help really guide these meetings going forward and guide the work that we do going forward for the next few years.
And I just want to clarify, when you talk about goals for the task forces, that's not the same as the goals in the cancer plan. So each task force will develop specific goals for the task force.
Yeah.
We're not necessarily asking for task forces to work on 2 full goals in the cancer plan.
Yes, and the way Carlin and I conceptualized it is that under each goal, we have these 4 objectives you see on your screen. And each of those objectives also have strategies underneath them. So the strategies, in some cases, there's 10, 12 strategies under each objective. So part of what's going to happen is Carlin has developed a survey that we're going to refine next week and send out to you that shows you what the strategies were that were identified as potential actions we can take to support that goal. And so when you get the survey, you're going to be asked to identify. I love that little.
I was trying to pull up the cancer plan.
Oh, I like that
there's
little hand thing, little
there's
thing.
method to my madness.
Oh, that's okay. So the idea then will be to look at all of those strategies under each objective and have us or help us refine that to say, what are your top 2 or 3 strategies for each of these 4 goals? So it is a matter then of distilling that data down from the survey so that when we meet on January 12th and February 9th, we'll be focused on 2 of the objectives for each of the meetings. So January 12th, we're going to look at the strategies for objective 8.1 and 8.2. So especially those of you who are viewing this or here present today who have strong interests in these areas, we really would like you to be present to have that discussion with us to refine which of those strategies we think we can take on reasonably in the next couple of years. And one of the things that Becky wonderfully reminded us of in a prior meeting is we don't have to move the needle from here to California. We just need to move it enough that we're making some progress in Colorado. And so it is a matter then of saying, what is it that our collective team thinks that they can work on that is smart, as in a SMART goal, that is specific, specific,
Measurable.
That's the word. I wanted to say manageable, but that's not right. Achievable, is that right? And then what is R? R is, oh, I should know this, reasonable, right? And then
something like that.
And
Yeah.
time bound.
Yes, time bound, so that we get specific enough around what it is we can do so that we can be successful. And it can be small things. It doesn't have to be huge. So on January 12th, we're going to be looking at the strategies for 8.1 and 8.2, trying to pare it down so that we can decide maybe one strategy for each one that everyone feels like they really can get behind. And then in February 12th, excuse me, we will look at objective 8.3 and 8.4 and all the strategies under that and be able to refine it down to which in those areas do we think we can prioritize and be able to be effective in making some progress. Did I capture that okay from what Christy, Carlin, and Becky understand as well?
Yeah, and I am showing Becky's comments in the chat front and center. So she put the link to the Colorado Cancer Plan as well as SMART objectives from the CDC.
Okay. Sounds good. And then Christy has agreed to help facilitate those meetings so that we can really make the time effective and meaningful for your participation and be able to land on something that we really think we can work on. And so everyone's input is really important. We have a membership of 180 some folks. And so we would like to get as much input as possible. We know that not everybody can join those meetings on January 12th and 9th, but we really invite you to be part of this action planning, if at all you can, for one or both of those meetings.
Denise, are you planning to send out calendar invites for those 2 dates? Or should
Well, that's part of what we've been discussing in terms of Krista or Bonnie, what do you think would be best? Would you prefer just to go ahead and get the calendar invite and then you can choose to attend, or commit to attending and then get the calendar invite? What would you prefer?
I might prefer to get the calendar invite first.
Okay.
And then, because I feel like there's kind of less back and forth with that in terms of scheduling and stuff.
Okay. And then if you.
But I'm able to be a little bit more flexible than maybe some other folks might be.
Okay.
So.
Okay. And so we will ask in the survey if people think that they'll be able to join one or both. So that will be part of it, in addition to identifying the top strategies that are most important and meaningful to each of the people who complete the survey. Christy or Becky, gosh, I just tried to morph your names. Do you have any other thoughts or anything I misstated or didn't state fully that we're aiming for?
We'll talk more on the 30th, Janice
Okay.
and Carlin, but I think we want to figure out too how to get data, some of the survivorship data we have, into the hands of people as they're doing the surveys.
Okay.
So we'll talk more about that on the 30th, but I just want to give you that heads up.
Sounds good. So we'll give you as much information as we have available that will help make your selections a little more meaningful. And then we'll take it from there. Now, as far as after we've identified one or two top priorities for the this particular task force, as far as action, and we set our goals, we are unsure about how much individual time it will be needed after that. Christy, do you have some guidance around, once we establish the action plans, whether these work groups will extend beyond January 12th and February 9th in your vision?
You know, each task force functions a little bit differently, but my recommendation would be that we'd put together work groups, especially since you all meet every other month. My recommendation would be that for each of the goals or priority actions that you pick, that we put together a work group, and then they meet in between task force meetings to continue the work. That's how colorectal functions. They have a few different task forces. So that would be an additional meeting. I mean, again, it's kind of up to the group, but either every other month or every month to work on that priority action.
Okay, so beyond the initial meetings to identify what those action steps and goals will be, we will begin to continue to meet probably in between our standard meetings to make sure that we're continuing to stay focused on the activity that's involved in that. So we are always respectful of your time, our time. We know that you're all volunteering your attention and time and talent to this task force. So we want to do our best to make sure whatever meetings we're holding, that they're meaningful, productive, and that they're keeping you engaged and helping you meet the goals that you've set for yourself in your own work. And so please continue to give us feedback with regard to what you need from us to help make this work for you as well, because we really, really appreciate and need your help to make this all work. So thank you, thank you, thank you. Any other comments or questions or thoughts about that? Bonnie or Krista?
I don't think so right now.
Okay. And do any of these topics strike your fancy so far? Anything in particular that you feel yourself drawn to?
Well, I am likely going to be starting a PRN position for palliative care. So I am especially excited about kind of seeing the one that talks about how palliative care can be helpful for folks, with chronic illness or who are, undergoing cancer treatment. So I think it's 8.3 and one of the ones under there.
Sure.
Can't find it right now, but
wonderful. Okay, sounds great. Yes, I think A3.
and I've got the
talk a
meetings
lot
on my
about it.
calendar, so I'll be there.
Awesome. I love it. I love it. Krista, how about for you? Anything in particular that you've seen so far that is of personal interest or professional interest for you or your team?
I kind of like I mentioned earlier, I just kind of hopped on this call. I think I just got on the maybe got the invite a week or two ago. And so it's all kind of a little bit new to me,
Okay.
So I'm not even 100% certain of this, of the purpose of this task force. I'm still kind of looking through that and figuring it out. So
Okay.
I mean, there's a lot of topics of interest to me at this point in time because I'm still relatively new. So I'm just kind of talking in circles.
No, that's quite all right. And if you feel like you need more time with Carlin and myself to talk about the purpose of the task force and where you might fit in, we're happy to do that. We spent some time with Bonnie early on and some other folks who've joined and weren't quite sure. So I think that's really important that we keep those discussions going so that you feel like you're getting what you need and what you came for.
Yeah, that sounds great. I mean, at this point, I'm just kind of looking, getting involved in things and, when I see something that looks interesting or, meetings or webinars or whatnot, I'm hopping on them just to kind of see what's out there and, to try and bring some of that back to our cancer centers within Centura and then obviously bring Centura out into the community as well. So, be happy to actually that sounds like a great offer and I think I would love to take you up on that maybe even after the new year here just find out a little bit more about kind of the purpose of it. Like I said, I just kind of hopped on and I thought, oh, this sounds interesting and I'm going to check it out, but I'm not 100% certain on the the intention of it and so forth, and would love to hear more about that and kind of how we can all put together.
Okay, that sounds fine. Carlin, for some reason the agenda dropped off. There you go.
Krista, I have a quick question. Are you on the mailing list for the Cancer Coalition? Do you get those emails as well?
I think I just got on it actually.
Okay, great.
I just got on that and then I got these and I'm not even 100% certain how I got on this email list. Because I just got on, it could have been from one of my colleagues, from one of the social workers in one of the other hospitals. I'm not certain.
Okay. It could be because we have a couple other folks from the Centura Cancer Centers that have
that's
been part of
probably
this
what
coalition.
was. Yeah, I know. It might have come through. Yes, we have maybe, I would say, 7 or 8 of us probably all together within the different Centura facilities. And so that would be my assumption as to where I got it and probably said, hey, this sounds great. Can I be on your list too? So that's why, and it just, being that I'm here part-time, being that it's a brand new role, I'm really just still kind of getting the lay of the land. So, so that's why I'm a little embarrassed that I don't know a little bit more about it than I should, but just trying to kind of figure out what's out there. So.
Well, no need to be embarrassed. We are glad to help explain how the coalition is functioning in the community in terms of promoting shared visions about providing the care that people with cancer need, as well as everything from the whole continuum of screening through end of life. So this particular task force covers a lot with regard to the experience of cancer. And so if that's part of your work role, this would be a good place for you to explore. So we appreciate the time and attention you have to offer.
Yeah.
So Christy, we probably can stop recording at this point. We're just going to go over the last few details and be able to